Hello and welcome to CAP21 Media Briefing. Thank you for joining us. My name is Dr. Emily Volk, President of the College of American Pathologists. We are here in Chicago at the CAP's annual meeting. Just when the country thought COVID-19 was in our rearview mirror, it gained speed, passed us on the left, and it just keeps going. Our members and our laboratories have excelled under extraordinary circumstances to continue to address COVID-19 testing challenges and the insurmountable demand for laboratory testing. While COVID-19 is at the top of our list, pathologists do way more than test for COVID-19. We have highlighted 4 sessions from our CAP21 program and have asked the presenters to discuss these with you today. For media who are joining us, please submit any questions for our pathologists during the briefing in the chat box. If we don't get to your question, be sure to follow up with CAP Media Relations team. First up, we want to give you a where are we when it comes to COVID-19 testing now, and of course, where are we going and what are we going to continually learn. I think this course is aptly named The Great Unknown. What's up with COVID-19 testing? Doctors Christina Wojwoda and Benjamin Pinsky join me today for this discussion. First, Dr. Wojwoda, could you please introduce yourself?
Hi, I'm Christy Wojwoda. I am the Director of Clinical Microbiology at the University of Vermont Medical Center and Associate Professor at the University of Vermont. I'm also the Chair of the CAP Microbiology Committee.
Where are we now seems to include something that happened just last week during a live television broadcast of The View on ABC. 2 of the co-hosts took a rapid COVID-19 test before the show last Thursday. They were then asked to leave the set when their test came back positive. Both were given several laboratory PCR tests, which were negative. Let's discuss the accuracy of rapid and at-home tests. Everyone seems to be talking about the tests, but not understanding necessarily how well they are working. And frankly, that's the most important question. I know for me, I took a few of these tests in my home, and my experience was that the directions were a little bit hard to read, that they were a little bit hard to follow. I had to be very careful in how many turns I made with the swab. I had to be very careful with how many drops of the liquid that I was to apply to the card, that I didn't get 4 drops instead of 3 drops, and that I didn't set the card down on a hot surface to potentially affect the outcomes. Dr. Wojwoda, what do we know?
Well, we know that rapid antigen tests aren't perfect. In this case, we had some false positive results. For me, false positive results aren't the worst thing in the world. These co-hosts were pulled from the set and retested for the ultimate safety of everybody involved. What really scares me about rapid antigen tests is false negatives. People who think they aren't infected and may change their behavior based on that result. We know that there's a study done in Florida that showed about 50% of the people who tested positive by a PCR test tested negative by an antigen test. So an antigen test can miss about half of the positive patients.
Dr. Pinsky?
Thank you. I agree with Dr. Wojwoda. The main concern with the rapid antigen tests is their relatively poor sensitivity compared to nucleic acid amplification tests or PCR-based assays. Dr. Wojwoda mentioned one study. There's a number of studies looking at these rapid antigen tests, and the results are consistent that in symptomatic individuals, the sensitivity is modest, and in asymptomatic individuals where they're being used quite frequently, the sensitivity is poor. In another study sponsored by the CDC that took place in Arizona, the sensitivity of the most commonly used rapid antigen test, the Binax Now, had a sensitivity of in the 30%. So there's a lot of concern about the performance of these tests, particularly if they're being performed infrequently.
Thank you for that, Dr. Pinsky. You know, we also know that federal workers and U.S. companies with more than 100 employees will be required to undergo weekly testing if employees aren't vaccinated. It seems that once a week may or may not be enough to accurately detect the virus. What are your thoughts on what's been proposed? I'll start with you, Dr. Wojowoda.
So I think while we would love to have testing every hour, even every day, our testing capacity within the United States is still a little bit restricted. And so I think once a week is an appropriate time frame to start with.
Dr. Pinsky, how about you? What are your thoughts?
Yeah, I think once a week is definitely reasonable, with the caveat that more sensitive tests than rapid antigen tests should be performed.
Wonderful. Well, I think our audience will be glad to know that. Now, what are some of the more important things that we have learned in the laboratory over the last year and a half when it comes to COVID testing? Dr. Wojowoda?
A year ago, I would have hoped that we wouldn't still be talking about this. Unfortunately, that's not the case. We are doing much more testing currently than we were a year ago. We're back up to the numbers that we were performing in January and February of this year. We've learned how to ramp up testing and ramp down testing. We've learned how to put up collection sites and have a stockpile of testing supplies ready to go when we need them. I think those are the big highlights from my laboratory.
It's amazing how laboratories and pathologists really had to quickly ramp all of this up. I think it's kind of like building an airplane while we fly it. Dr. Pinsky, can you share your experience?
Yeah, absolutely. It was incredible ramping up of capacity and testing numerous different methodologies, mostly nucleic acid amplification, tons and tons of validations with different specimen types and different swabs and so on and so forth. And then I'm not sure, we may get to this, but the supply chain issues that I think all laboratories dealt with and continue to deal with, obtaining the reagents and consumables necessary to actually keep up with all of this testing has been an incredible challenge and something that I think we need to learn from and improve for the next time this happens.
Oh, absolutely. I can tell you in our lab, we also, experienced the effects of the shortage that was there for medical plastics and certainly other kinds of lab testing equipment. Can both of you talk about this current wave of COVID and what effect all of this is having on our overall lab operations? Dr. Wojowoda?
We've learned that the assays currently in use, the tests that we use in our laboratories most commonly, do detect the Delta variant and continue to detect new variants. And again, having to ramp back up to high testing numbers has been something that we've had to do, going from low testing numbers in July up to our max capacity again.
Thank you, Dr. Wojowoda. Dr. Pinsky, can you talk about how the ramping up of COVID testing has had other effects in the laboratory for, say, hematology testing or other microbiology testing?
Sure. Yeah, I'll take the latter there. For microbiology and virology testing, certainly we couldn't run our batch test as frequently because our staff was performing COVID testing. So we had to significantly increase our staffing, of course, but our turnaround times for other testing certainly suffered, and we're just now sort of trying to get back to providing that standard of care for all of our other tests.
Well, again, I mean, we are so grateful for your leadership and Dr. Wojowoda's leadership to make sure that our patients get all of the testing that they need for their care. You know, at this point, I think I'd really like to learn more about your thoughts on testing for immunity or protection for the virus. Is there a test for that now? I'll start with you, Dr. Pinsky.
Yeah, that's a great question. One of the many questions of the hour, as it were. I would say right now that while there are some quantitative serologic assays out there, we don't quite yet have correlate of protection based on those tests. I think that there's a lot of folks working on that, but it's a little bit, I would say, a little bit tricky, and we're not quite there yet.
Dr. Wojowoda, what are your thoughts?
My thoughts are serology testing has very limited use. Knowing if you have antibodies to the virus isn't helpful to know if you're protected or not, as Dr. Pinsky said. We don't know what level of antibodies you need to be protected. So in our laboratory, we restrict the use of serology testing for only those patients who may be presenting with a complication of COVID-19, like a clot, and didn't have a diagnosis of COVID-19 prior, or in pediatric multisystem inflammatory syndrome. Serology can be useful in that situation as well. So we send out very few serology tests.
So what I'm hearing both of you say is that there really isn't a magic bullet test, if you will, that says, I'm good, I don't need to socially distance, I don't need to wear a mask, I don't need to worry at all anymore. We still need to be following the guidelines for social distancing, for masking, and encourage everyone who isn't vaccinated to still get that vaccine, but understand that those antibody tests and those titer tests that are out there that are being touted as a way to monitor how protected you are really not ready for prime time. So because laboratories are inundated with COVID testing, are you all seeing any staffing problems? And if so, can you tell me about how that's impacting your lab? Dr. Pinsky?
Maintaining and recruiting staff. Obviously, we've had to increase our staffing to keep up with the testing volumes. I've been supervisorless for quite some time now, so if anyone has interested in working at Stanford, here's a plug. But yeah, the staffing issue is a significant problem.
Dr. Wojowoda, what's your experience on the East Coast?
I agree. If anybody is out there looking for a wonderful career choice, I would encourage you to go into medical lab sciences. It's a very fulfilling career, and we need many more medical lab scientists to help us keep up with all of this, the COVID-19 testing, but testing in general.
Yeah, I couldn't agree with you all more. These are critical partners in our laboratory operations. You know, I also think it's very important to remind everyone not to put off regular testing, like testing for cancer screening and diabetes. Could you all talk about whether pathologists are seeing higher rates of more advanced diseases because folks are delaying testing? Dr. Wojowoda, I'll start with you.
I can comment on some of the things I've been seeing in the microbiology laboratory. We've definitely been seeing patients come in with more severe illness, more advanced infections than we usually would. We also had 3 patients come in last week with abdominal aortic aneurysms, which was terrifying for our surgical staff and our transfusion medicine service to try to keep up to take care of those patients. Again, we were seeing people who haven't been able to get regular checkups, haven't had a physical exam in person in a while, or have been scared to come into the hospital. So we're definitely seeing more severe illness.
Thank you, Dr. Wojowoda. Dr. Pinsky, this next question I'll direct to you. What else is important for people to know about the state of COVID-19 testing?
I think I'm going to emphasize that the diagnostic testing by molecular methods is very accurate. I think that folks should get vaccinated. You're hearing this all the time, and continue if you're at high risk, or to continue to wear masks and social distance in certain situations.
Thank you, Dr. Pinsky. Now, at this point, we're going to try to answer some questions from our reporters who are joining us virtually today. So we have a question from Max Bayer, CBS News. At the beginning of this month, the CDC alerted labs that there was a shortage of point-of-care and over-the-counter tests, and the agency recommended lab-based testing whenever possible. So are labs now, similarly to last summer and fall, dealing with a surge in demand that's hard to keep up with? Dr. Pinsky, what's your experience at Stanford?
Yeah, so we've had certainly a surge with Delta over the last month or two. That, at least in our area, that surge is beginning to abate. But we've been able to keep up with that with laboratory testing. Throughout the course of the pandemic, we've been able, as Dr. Wojowoda said, respond and stand up more testing as needed, and then relax as we get into the valleys between these different surges. So at least for us, we've been able to maintain the testing.
Dr. Wojowoda, how about you?
We've been able to ramp up testing capacity when needed. We've had to send out some testing, but we're still able to keep 96% of our results coming back within 48 hours, which I think is appropriate, and our average turnaround time is 23 hours. So we're able to continue to increase testing while still providing results within a relatively appropriate time frame.
So it sounds like y'all are keeping up but working really hard. A follow-up question that we're seeing is, in the context of schools starting nationwide, again, are you feeling like you can continue to maintain that adequate turnaround time so schools can have those safe in-person classes happen? Dr. Wojowoda?
We've definitely been hearing from parents who have needed to get their children tested so that they can go back to school. And so we've tried to keep that, average about 24-hour turnaround time available. But definitely we've seen increased demand for testing in our school-age population, and in the children that are too young to be vaccinated, seeing increasing positivity rates in that age group.
And Dr. Pinsky, out in Palo Alto, what does it look like for schools there?
Yeah, it's very similar to what Dr. Wojowoda has described.
Wonderful. Well, Drs. Wojowoda and Pinsky, thank you so much for joining us today. Next, we will discuss COVID and the importance of autopsies, so please don't go away. Welcome back to the College of American Pathologists Media Briefing. Joining me now are Drs. Carolyn Glass, Jonathan Thompson, and Alex Williamson. Can you all please introduce yourselves to the audience? I'll start with you, Dr. Glass.
I'm the Chief of Cardiovascular Pathology, as well as the Director of the Autopsy Service here at Duke University Medical Center.
Thank you. Dr. Thompson?
I am a forensic pathologist at the Iowa Office of the State Medical Examiner.
And Dr. Williamson?
Hello, everybody. I'm Dr. Alex Williamson, based at Northwell, just outside of New York City. I'm Director of Autopsy Pathology, and I'm also a pediatric pathologist.
Well, thank you. You all are all on the front lines of autopsy. In fact, the autopsy is a vital tool to understand and respond to COVID-19. What have we learned in the last year and a half about those who have died from COVID-19? Dr. Glass, would you like to start us off today by talking about how your institution handled and adapted because of COVID? And then Dr. Thompson and Dr. Williamson, can you then share your experiences?
Sure, thanks for the question. I think it's been a really remarkable time for all of us in this field. I think that first, when we found out about the pandemic, I think the first question was, well, how is it affecting our society as a whole in terms of mortality rate, and what can we expect in terms of just the amount of the number of autopsies that the families will want for us to perform, and if our institution was even equipped at the time, for safety reasons and staffing, and just being able to be trained in the appropriate standard of procedures required to safely perform the autopsy. So those were some hurdles that we had to overcome initially. So I don't know if that answers your question, but the good news is the mortality rate, I mean, it's not like SARS-CoV-1 where it was much higher, and MERS where the mortality rate was in 30s. So we found out, now it's about 1 to 2%. So I think knowing that really helped us organize what we're to expect.
Well, thank you for that. Can you tell me why it's important that COVID deaths be certified accurately and autopsies be performed, Dr. Thompson?
Yeah, well, first of all, I think we owe it to the people to certify the death properly. That deaths are the last clinical diagnosis we're going to have. We owe it to the people who are ethically right. Second, if done properly, the deaths are summary of why the disease died. That can really provide a lot of closure for the deceased families. And for whatever reason, deceased families tend to be interested in knowing whether or not their loved one died of COVID, even more so than other types. The primary reason why deaths are utilized is because epidemiologists want to examine and study why people are dying with the intent on preventing other people following in the pathway of our patients, or at least prolonging that path of our patients.
Dr. Williamson and Dr. Glass, can I get your thoughts? Let me start with Dr. Glass.
Could you repeat the question for me, Dr. Volk?
Sure. So can you tell me, why it's important that COVID deaths be certified accurately and that autopsies be performed for these patients?
Okay. I mean, I think it's very important. I mean, as in all matters of autopsies, the family needs to really have closure as to, what actually caused the death in their loved one and their family member. I mean, determining a cause of death is very important for, again, for closure for the family. They want to know, was there anything done that we could have assisted with? Or there's also legal matters, and and also in terms of depending on what the disease process was, if it would affect their, would also affect themselves or their nearby family members. So, in the case of COVID, many families want to know, was that really what caused the death? And there was a lot of fear around the disease. So even how is that going to affect us and our family members? So I think just having that knowledge was helpful for the family.
So that clarity was just very important for patients' families. Yes, I can understand that. Let's move on to the next question. And Dr. Williamson, can you tell us how a COVID autopsy helps us treat the living?
So great question, thank you. And I just want to echo what my colleagues have been saying about the important role of autopsy. And really, it's important to realize autopsy is about the living. We obviously have the benefit and the privilege and the responsibility to examine those who have died, for the family, for the clinicians who cared for that patient, and for the public, all of us, in the sense of public health. I think understanding not only COVID pathology, what actually the virus does to our body, it was very important to figure that out early on in the pandemic, and I applaud our pathology community that jumped into the fight, if you will. Our clinical colleagues were on the front lines in the ICUs and the EDs, treating and managing and caring for these patients, and we in pathology were also caring for our patients in the way that we get to, which is to in the sets of autopsy, when they do die from a disease, we need to understand what's happening and share that information almost real time with our clinical colleagues so they can better manage the next patient to come in with that disease. So early on, the role of autopsy was one of helping understand what was coming our way in medicine and to be able to better respond to it. And then tying it back to that cause of death statement, we all benefit from understanding what is truly killing people, as has been said by my colleagues. I think it's important to realize that through death investigations, such as in the setting of COVID, we also understand other factors that play a role. For example, we know that COVID tends not to kill healthy people. People that die from COVID tend to be those with other comorbidities, particularly obesity, and then cardiovascular disease such as hypertension or atherosclerosis. I think it's important to understand not only what is directly responsible for killing someone, but also understanding other pathologies which we then can hopefully intervene on in our society. Obesity remains a huge health problem around the world and in the United States, and I think we saw that with COVID. In truly understanding how COVID is killing, but also the people that are at risk of COVID, we're hopefully better able to inform the family members of those who have died, the clinical team, so we can better triage patients. And then we as a public need to realize that we all have a role to play in not only COVID-19, but future diseases and pandemics in which we can do a better job, I think, at managing our health and getting the word out about comorbidities that may make us more vulnerable to the next infection, which will be coming. We had 6 viruses that have changed the world over the first 20 years of this century: West Nile, Ebola, H1N1, SARS-1, Zika. Now we're with COVID-19. There'll be another one. And we can, I think public health can hopefully be better prepared for the next pandemic.
I really appreciate you highlighting the public health role that trained forensic pathologists can play and do play in our communities. Dr. Thompson, would you like to add to these comments? How does a COVID autopsy help us treat the living?
Basically, exactly as Alex said, I think through autopsy studies, we realized that a lot of the disease process is attributed to a hypercoagulable state. Early on, a lot of physicians started to those blood clots. Exactly like Alex, the best way to understand why people are dying are through autopsies, and hopefully by understanding why people are dying, we can help people living.
So to sum up what you're saying is the reason you all focus so carefully on the cause of death is to help those who survive and help us be prepared to treat the folks who remain.
I think elucidating, just as Dr. Williamson said, just being able to have the tools to elucidate at the tissue level what is going on mechanistically is really a huge benefit. That is a really unique resource that we have as an autopsy team, because I think a lot of the pathophysiology, basic pathophysiology of what the virus is doing and in what tissues is very helpful and facilitates not only treatment, but future treatments, as Dr. Williamson noted.
You know, one of the things that I really treasure about being a pathologist and I'm particularly proud of is the fact that as pathologists, we get to stare disease right in the eye every day. So as you all are doing your autopsies and you're looking through the microscope, you all get to see on the front lines exactly what's happening at the cellular level. And again, I mean, that information and the way you all convey it to other colleagues is so critical. You know, safety is certainly a key issue for all autopsies, especially being that COVID-19 is highly infectious. Dr. Williamson, can you start by giving us an understanding of why safety is of the utmost importance and what you do to ensure it in your autopsy practice?
Sure, a very good question. And I know, again, kind of back to the early stages of the pandemic, there were a lot of questions. In fact, the autopsy community came together and shared experience and thoughts and ideas about how best to proceed, because whenever one is dealing with an unknown disease, it's exciting in the sense of the unknown. We have a chance to learn about something new and understand it and break it down and eventually beat it in the context of clinical care with our colleagues, the team effort. But the questions surrounding COVID-19 were like, really, what type of infectious disease is this like? Is it like tuberculosis? Is it like HIV? Is it like hepatitis C? Or is it like prion disease or mad cow disease? This was unknown. We had a new disease the world had never seen before. And coming together with our shared experience, we were able to come up and with guidance from government agencies such as the CDC, erring on the side of precaution, we were able to use what we already have in place. Autopsy practice is a wonderful, exciting, and safe practice of medicine. The reason it is safe is we have safeguards in place, such as adequate ventilation, training and experience of those conducting autopsies, and an appropriate understanding of hygiene and sanitation. So bringing all of our usual daily experience to bear was the first step. And then taking precautions such as, we didn't understand how the virus was spread on surfaces. So So how does one handle body bags in the setting of decedent management, morgue management? That was also learned as we went along. But I guess I would emphasize kind of how we got through is we relied on our sound principles. And I think that speaks to the importance of supporting autopsy education and training, because again, when the next pandemic comes, the next generation has to be able to respond and answer the bell. And if they don't have the tools, the training, and the resources as autopsy pathologists to do that, all of medicine and therefore all of public health will suffer. So it's safe because we learn how to do autopsy, we practice autopsy, we teach autopsy. We're able then to apply those universal precautions in that procedure to any challenge that comes our way. And that's kind of was my perspective, but it was really the community of autopsy pathologists coming together to share experience and knowledge to come up with the best way forward, which did rely on what we already knew. We just had to tweak a few things here and there, but I don't think anything was really overhauled in the setting of COVID-19 because we knew what we were doing from other infectious disease.
No, that's a wonderful answer, and I appreciate you bringing to bear the importance of the collegial community of pathologists that's there, and certainly we continue to support through the CAP and our annual meetings and continued educational programs. We'll go to the next question. Dr. Glass, what types of stresses has COVID placed on what seems to be an already encumbered autopsy system?
That's also a great and very real question. In the beginning, I guess it was really the fear of the unknown. Again, as we said, we don't know. We didn't know what the virus could do, but we did have safeguards, again, from policies that were established. But we made sure that we had a very strict, very reliable standard of procedure in place. But some of the stresses that came on a lot earlier, more so than now, because it's been almost 2 years. But in the very beginning, some of the stresses were: do we even have enough PPE to make sure that we are doing things safely? What is the mental and emotional stress it's going to cause on those who are actually performing the autopsy? Because again, we didn't know what we knew. It was safe in the sense of we had the appropriate PPE based on the guidelines, but there was a lot of anxiety in the beginning. But as we realized, as we adhered to an RSOP, and I think those fears kind of slowly diminished, and we're able to do things a lot more streamlined. But I think that to be real, it was quite emotionally, I think, hard, and I'm very thankful that the colleagues on this call, as well as those across the country that chose to perform these autopsies, did so, because I think it takes a lot of courage from not just the attendings, but really from the technicians to everybody that was involved, to say that I'm going to be part of this, and it's important for our society and our community to have these answers. So.
Well, I want you all to know how much I appreciate the commitment of our forensic pathologists in the United States who, during the pandemic, continue to run into the burning building, not away from the burning building, to do this important work and do it safely, but not. You didn't put your own interests at first. You put the patient's interests and the public interest first, and you continue to do that, and I certainly appreciate that. Doctors, is there anything else important you would like us to know about COVID autopsies? Dr. Glass.
Well, I think, thank goodness that the mortality rate of COVID is not high, but it does continue to kill. And I think it's important to continue to study through autopsy with families that are willing to contribute to science and research to study what happens after you get infected with COVID, because COVID is something that affects, it's multifactorial. It doesn't just affect the heart. It affects, as we talked about, the vessels and other organs. And it's important to understand what this virus is doing long-term to our bodies, including, how it affects us psychologically and, in terms of cognition and, other post-COVID type symptoms. So I think that autopsy will continue to be a very really a valuable resource to continue to study this phenomenon.
Absolutely. We've got a question now from the media who've joined us. Dr. Williamson, as we are now coming towards 2 years into the pandemic, what are some of the top implications of autopsies you've learned when it comes to public health, especially for COVID-19?
Well, I would say in terms of, as Dr. Thompson stressed, the importance of death certification, I think, is number one from a public health perspective. Not only with COVID-19, we need to know what's killing people and how. A lot of us take it for granted when we walk around in society and see warning signs on the streets or on vending machines or in pails of water with children or any toy that has not for age under 3. All of these guidelines that we live by essentially came from the investigation of unfortunate deaths. But the reality is these deaths happen, we learn from them, then hopefully we improve those that are yet to come, those that follow, those that are still alive. And again, emphasizing that point of autopsy is all about the living in the forensic setting and the hospital setting. So COVID-19 really helped the clinicians treat those who continue to come in, especially in the early weeks and months of the pandemic. We were learning pretty much on a daily basis with each autopsy what this disease was doing and what we had to do to counter it. And we got really good over the first few months into the first year of the pandemic. And now we switch to a world where many people are vaccinated. We need to remain vigilant for the role of COVID-19 in causing disease and the efficacy of the vaccine. And vaccines, as we know, appear to be incredibly efficacious. They keep people out of the morgue, if you will, and prevent them from having an autopsy. We know that now. That's good. We need to continue that, as Dr. Glass said, that surveillance of what COVID does in the long term, and continue to provide accurate data to the policymakers of our governments so they can make accurate decisions about masking and social distancing and opening schools and allowing events, et cetera. All of us are impacted by COVID-19. And unless we understand what COVID-19 is and how it works, we're not going to be beneficiaries of accurately or well-informed decisions by our public policymakers.
You know, all of you today have highlighted, what I think is a core function and a core value of pathologists, and that is truth. Seeing the truth, finding the truth, and telling the public what is real and what is true. So I would like to thank all of you today. Unless there's other questions from the media that that we have to share, it doesn't seem like we do. So thank you very much. Drs. Thompson, Drs. Glass, Dr. Williamson, thank you so much for joining us today.
Thank you.
Thank you.
Welcome back to the College of American Pathologists Media Briefing. I'm Dr. Emily Volk, President of the College of American Pathologists. Now we're changing gears away from COVID-19, and we're going to focus now on hereditary cancers. October is Breast Cancer Awareness Month, and today we're going to talk with 2 pathologists who specialize in breast disease who will discuss hereditary breast cancer and some exciting emerging therapies and predictive tests in the treatment of this cancer. Welcome Dr. Rania Bakar and Dr. Anupama Nayak. Dr. Bakar, will you introduce yourself?
Sure. Thank you, Dr. Volk. And I am really excited to be here with you today. I'm an associate professor of pathology at Cedars-Sinai Medical Center in Los Angeles, California. And I specialize in women's cancers, mainly breast cancer. Again, I'm excited to be here and ready to talk to you about this topic.
Thank you so much. And Dr. Nayak, can you also introduce yourself?
Thank you, Dr. Volk, for having me here. I'm Anupama Nayak, and I'm an associate professor of pathology at the Hospital of the University of Pennsylvania, where I primarily practice breast pathology, and hereditary breast cancer is one of the areas where I am very, very interested, especially the Vassar Center being part of the Hospital of the University of Pennsylvania. So I'm really glad to be here and looking forward to it.
Well, wonderful. Well, let's get started. Let's talk first about the emerging and current therapies along with predictive tests in the treatment of hereditary breast cancer. I'll start with you, Dr. Bakar.
Sure. So patients with hereditary breast cancer or any type of breast cancer that shares characteristic features of hereditary breast cancer in the form of deficient or defective DNA repair, what we call homologous recombination deficient cancers, have been shown through numerous studies and large-scale clinical trials to be sensitive to certain therapies, new and highly effective therapies such as platinum-based chemo and PARP inhibitors. They are such as olaparib or talazoparib. These drugs are targeted, meaning that they target specifically cancer cells with the defective repair mechanisms. Therefore, they are efficient and less toxic compared to standard chemotherapy. And that's not only in the advanced setting of the disease. Recent studies have also shown that it's effective in early stage breast cancer, which is quite exciting. And so as for the predictive, the second part of the question, the predictive biomarkers or tests that are available. So basically, not all patients can benefit from these types of targeted therapies. So it has become clear to us as pathologists that there is a real need for developing robust and clinically feasible predictive tests to help select patients that would benefit the most from this targeted treatment with the least side effects. So there are multiple predictive tests, such as ones that are currently in clinical use, such as the multi-gene panels, and others that are being investigated for the use in breast cancer patients, such as polygenic risk score, homologous recombination deficiency score, and RAD51 assay, which is a functional assay. So there are many promising treatments out there and predictive tests that can help deliver this treatment to the right patients.
That is incredibly good news for any future breast cancer patients out there and current breast cancer patients. And the focus on trying to find the targeted therapies with the huge input of the pathologists that minimizes side effects, I think is so wonderful. And I know that our patient community is grateful for that. Dr. Nayak, can you give us a little bit more about genetic counseling and why it's important to the patient?
So that's a great question, I would say, because genetic counseling is kind of an integral part of germline testing. In fact, the current recommendations from American College of Medical Genetics and all, they say that no genetic test should be actually performed without a pre-test or post-test genetic counseling. And we need to realize that this is a very, very complex subject. Even some of the clinicians and we pathologists do not have a very clear understanding of the nitty-gritty details of the underlying genetics. So these genetic counselors or geneticists, these are trained professionals in this field. So when you meet as a patient or a family member, these genetic counselors, they can review your personal and family history in detail. And based on that, they can calculate the actual risk of developing a lifetime breast cancer or having any other inherited cancer gene using various mathematical models, actually. So it could be that you were referred to a genetic counselor, but when all the features were put into those algorithms, that your risk is not that high. And you do not need a genetic test. So they can help in doing that. You can forego a genetic test there. Then they can explain what the genetic testing entails. They can help you in choosing the right test for you based on the cost and the insurance coverage you have. And, there are numerous commercial tests actually available in the market, different types of tests, and they can help you in actually customizing the gene panel for you based on your personal and family history and the anticipated cancer gene, which can contain some cost of the test. They can also explain you the limitations of a genetic test, meaning what the test can tell and what it cannot tell. They can talk to you about the ramifications of a positive or a negative test result, like how a positive test result is going to impact your future cancer care or cancer screening, how it is going to impact your sons and daughters and other close relatives. The other thing these tests can do, that they can explain you the implications of the negative test result, because negative test result does not mean that you can forego a high risk cancer screening. So all these difficult subject matter, these genetic counselors, they can help in explaining and describing it. And in nutshell, to cut the story short, I would say that meeting with the genetic counselor gives you the opportunity to participate in the shared decision making so that you can carefully weigh the benefits and risks of genetic testing. And ultimately, if you decide to go for genetic testing, the genetic counselor can also help you in explaining the test results, what the results mean, both for you and your family members.
So building on the importance of family history, does knowing your family history help to catch most cases of breast cancer? Dr. Bakar, can you tell us your perspective on this?
Sure, it certainly helps in some cases, it has been known for a long time that it does. However, some recent studies have shown that relying only on family history can miss up 50% or more of patients with inherited mutations that can be helpful in deciding preventive or therapeutic treatment or options. So there are mainly a couple of hurdles with relying on family history alone. The first is that we need a detailed family pedigree, preferably up to 3 generations, which is not feasible for most patients. And the second thing is further compounded by the variable inheritance patterns of genetic mutations, which we refer to as penetrance, meaning that mutations can be inherited and can be present in an individual, but whether or not they are expressed in the form of disease varies from generation to generation and from individual to individual. Therefore, relying on family history alone can be tricky, and right now, molecular genetic testing are much more feasible compared to 20 years ago, and readily available, and can help in combination with family history, personal history, lifestyle, and so forth, can really help make the guidelines clearer and the treatment options available.
Thank you so much. Now, of course, you're both pathologists, and obviously the genetic counselors play an important role, but tell me more about the importance of the pathologist when it comes to guiding women and men to the right tests and treatments, and why pathologists are really so important in identifying these hereditary breast cancers. Dr. Nayak?
Yeah, so that again is an excellent question. So the way I would say that we pathologists are very uniquely positioned in a multidisciplinary cancer care team. We are almost at the center stage where we are constantly guiding our clinicians by our input. So just to give you an example that when we get a slide of a breast cancer and we make a diagnosis, so it's not just a diagnosis of breast cancer, it is more than that. So if I see a breast cancer has a very well circumscribed margin, it has a lot of lymphocytes associated with it, the patient is very young, it has a triple negative subtype. So all these features combined, the next step I would do that I will make a phone call to the clinician, and tell her that, hey, I see this patient is very young and she has this kind of breast cancer, which has these medullary features. So maybe she has a BRCA1 associated tumor. So has she been tested for germline testing? Okay, so these kind of communications we always have. So that is one thing starting from the cancer diagnosis. Now, the other example I can give, like these days when the patients come with a very advanced cancer or a metastatic cancer, okay? So molecular testing again of a solid tumor is an integral part of our pathology functioning. And in those solid tumor panels, many times it happens that the germline mutations are highlighted because of the very high mutational allele frequency. And especially if we have performed that solid tumor panel paired with a normal tissue, that gives us another opportunity to detect these kind of germline mutations and recommend further germline testing in those patients. So that is another example. And again, as Dr. Rania mentioned about the predictive assays and the therapies, etc., which she can talk more about it, that is another opportunity. So Dr. Bakar, would you like to?
Sure, Dr. Naik. So the pathologists really wear many hats in this era of personalized medicine. And we basically, the thing is, not all, unlike ovarian carcinoma patients, for example, breast cancer patients do not routinely get tested for genetic or molecular abnormalities. Therefore, pathologists really play a critical role, not only in identifying the breast cancer patients that would benefit from treatment or can be diagnosed with hereditary breast cancer, but also in selecting the best. Like when we get a request for a test, we have the role of selecting the best sample to be tested. And also we can be very helpful to our clinical colleagues in selecting the test, the biomarker test or the predictive test that would help identify patients that would benefit the most from any given therapy in the most efficient and cost-effective way. So as Dr. Naik mentioned, we have a communication role, we have an interpretive role, we have a selective role, and we can lead the pathway for better testing and tissue sampling.
So you all have done a great job. Really detailing how the diagnosis is so important to the subsequent therapy, right? So we have one of our members of the media who has a question and they're asking if we could talk a little bit more about targeted therapies and a little bit more detail about those therapies for breast cancer, because we all know that the healing starts with the right diagnosis in the laboratory. So, Dr. Naik?
Yeah. So the therapy-wise, as we said, that in the realm of breast cancer, we are a little behind compared to the ovarian cancer, but we are moving forward in that dimension as well. So now we do have FDA-approved treatments like olaparib and talazoparib, which can be used in patients who come with the metastatic breast cancer, and they have already failed the prior standard chemotherapies. So based on your mutation profile, and most of these hereditary breast cancer genes, they are implicated in this DNA repair pathway. So it doesn't matter that if it is a BRCA1 mutation or it is a PALB2 mutation, all those clinical trials exist now where these patients can enroll and go for these targeted therapies. Also, not only in the metastatic setting, now we have approval for even the early stage. There are clinical trials which are going for even the early stage breast cancers associated with these hereditary cancer genes. So like recently there was an Olympia trial and the results were very promising in showing that with this treatment, the targeted therapy, the patients did very well and they had an extended progression-free survival.
And may I add that also not only in the adjuvant, which means we refer to adjuvant meaning like at the current stage of the disease. Usually it's an early stage of the disease. There is new adjuvant chemotherapy now, so you give the chemo before the surgery, and one of the most recent studies that was published by MD Anderson recently showed that talazoparib, which is one of the targeted treatments that can be used in breast cancer, shows very promising results and complete response to chemo before surgery, which has a really great prognostic value. So I think we are living in a very exciting era for breast cancer patients that can benefit from these targeted treatments. And by targeted, they are less toxic because standard chemotherapy just hits every cell in the body. And so therefore it can be quite toxic. But targeted treatment, on the other hand, only targets cancer cells. So you can imagine that just the cancer cells are going to be affected and therefore it is less toxic. And there are ongoing clinical trials to see if we can combine different types of targeted therapy, not just PARP inhibitors like talazoparib or olaparib, also immune checkpoint inhibitors such as pembro. So it's a very exciting era, and the advances are numerous, and pathologists really play a critical role in deciding which patients can benefit from which treatments the most.
Well, I really appreciate your updates today, and thank you both, doctors, for joining us. Our next topic has to do with cyber attacks in the laboratory and what that means for hospital systems and, of course, most importantly, our patients. We will return in a moment. Welcome back. Cyber attacks. Many of us have been a victim. They are becoming more and more frequent, but how about when it happens within a hospital system's laboratory? Dr. Andrew Goodwin is here to help us understand how important it is to protect our laboratories from cyber attacks. Dr. Goodwin, thank you for joining us today, and would you please introduce yourself?
Thank you, Dr. Volk, and thank you to the CAP for inviting me today to share in our experience of our cyber attack. So I am Andy Goodwin. I am a medical doctor who is board certified in anatomic and clinical pathology. And in my role, I serve as the director for our hemostasis and thrombosis laboratory. That's the laboratory that is responsible for providing laboratory results that help in diagnosing and managing patients who have bleeding and clotting disorders. I'm also an educator and a professor at the the Larner College of Medicine at the University of Vermont. And I currently serve as the vice chair for my department in quality and clinical affairs and oversee our hospital network laboratories.
That's wonderful. Well, we're really glad you're here with us today. Can you first share with us what happened at your institution and what was the cost, both certainly financially, which I think is easier to see, but also to the very private information stored in the hospital, certainly including the laboratory?
Absolutely. So one of those events that we all have events in our lives where we remember where we were, and I remember where I was on October 28th when our laboratory and our hospital actually was the victim of a cyber attack. Our information technology systems, our communication systems, our electronic health records were all taken offline as a measure to protect patients' healthcare information. And the reason that we had to do that is because malware had been installed onto our system through no fault of anybody at our institution, but through cyber criminals who targeted our organization. The hospital made the decision to literally take all of our services, electronic services, offline with the goal of protecting patients' health information. And therefore, our laboratory, along with with our healthcare organization, had to really move towards manual effort to deliver healthcare to patients in our hospital.
Wow. So can you tell me a little bit more about the extensive impact this had on the anatomic and clinical pathology laboratories?
Absolutely, sure. So again, we're a tertiary care medical center. We're about 620-bed hospital. We serve as a regional reference laboratory for all of the state of Vermont and partners in upstate New York and New Hampshire. And we had this cyber attack that lasted 25 days. And the impact on our laboratory services was that we were really rendered unable to use our automated systems, to use our health record, our electronic health record, and really to deliver efficiently the laboratory information and anatomic pathology diagnoses that's necessary for patient care. So it was really, really important for us to move to a manual process and work with our colleagues both in the hospital, our physician colleagues, with our hospital incident command centers, and with our clients that send us laboratory testing, and figure out how to deliver these services safely and as timely as possible.
Do you have specific examples that you recall from this incredible event where patients were directly impacted?
So, I would say from the laboratory's point of view, I don't have any specific events. We did ask patients not to seek laboratory services for just routine care. So, having an annual exam where you would get laboratory work, we asked the community and our providers to try to reduce the number of patients that were accessing our laboratory for those services so that we could deliver laboratory results and do testing on patients that needed acute or urgent medical care. So certainly patients were impacted by just routine standard care that might have been associated with a well visit, for example. I will say that in our anatomic pathology division, our turnaround time, in both clinical and laboratory medicine, or anatomic pathology, our turnaround times were extended, but not so much so that it impacted the patient to my knowledge. And I will also tell you that our division of anatomic pathology processed nearly the same number of tests and specimens that they had done over time, and we have no record of losing one patient sample.
Wow. So, I mean, it really sounds like your team rallied and focused on the patient, put the patient first and made it happen.
Yep, absolutely.
That's awesome. So what are laboratories across the country, and what are you all doing up in Vermont to prevent this kind of thing from happening again?
Sure. So it's really important that healthcare organizations, laboratories really instill upon their employees that we have to be mindful that there are cyber criminals out there, and that we really need to follow the best IT security policies and practices, such as not checking personal email on a hospital laboratory or an employee's laboratory, really not clicking on links and things like that. I know it sounds simple, but I will tell you that in our institution, this event occurred unknown to the person that was actually reading a legitimate email that the cyber criminals had embedded malware into. So we were sort of a secondary victim, if you will, through no fault of anybody's at the hospital.
Wow, so really downstream, a couple of steps in a completely legitimate email.
Correct.
They hijacked that and got into your system.
That is absolutely correct.
Oh my gosh, that is frightening.
Yes, it is. Yes, it is.
My goodness. I know in our hospital we hear a lot from our IT security folks about how we need to be careful for phishing scams and so forth. But wow, to have a routine email.
Yep. And I can tell you that at our institution, I mean, they certainly have heightened the restrictions, if you will, on what we're able to access using work-related computers. They now send out, our IT security team sends out phishing emails, if you will, to employees to make sure people are following the rules. And if not, they provide education back, informing people what they should and should not do when they receive an email. Our malware and antivirus softwares have obviously been upgraded significantly. I mean, even though we were running the latest technologies, they really have implemented additional steps to reduce the likelihood that we would be a victim again of a cyber attack. It might sound like this could be costly, but keep in mind our hospital lost somewhere between $50 to $60 million during this cyber attack.
And that's monies that could have been used to help treat patients.
And it happened during a pandemic.
Yes. Oh my gosh. Well, it sounds like your IT department is taking a page out of the laboratory quality book with having, if you will, proficiency testing of email safety to allow folks to make sure that their email practices are the safest and the most compliant, and they can recognize a potentially dangerous email.
Absolutely correct. And I think back to the question you asked about what can laboratories do, we all have downtime procedures. We all write procedures. We follow the College of American Pathologists best practice using our checklist to have our downtime procedures. This was beyond the scope of what we typically experience in a downtime. We've all experienced downtimes, both planned and unplanned, but 25 days with the extensive nature of the downtime, I mean, to the point where fax machines didn't work, phones didn't work, pneumatic tube systems that deliver specimens, anything that was controlled by software was essentially rendered inoperable.
Wow.
And so we have upped our game, if you will, and we have drafted additional steps in our downtime manual really to handle these sort of catastrophic events, whether it be a cyber attack or some other horrible catastrophic event. Yep.
Wow. Well, you've really touched on my next question, which is great. You know, why it's so important to remain nimble and react swiftly when these critical situations arise.
Right.
And you've described some of the things that we can do to stop these attacks. But tell me, I think we might have a few questions from our media friends.
Sure.
Give me just a minute and we'll see what they have to say. Okay, fantastic. It looks like one of our media members is asking, when a hospital is compromised by a cyber attack, from your experience, Doctor, how have you mitigated critical care situations from becoming worse?
Sure. So we recognized, we did some risk assessments early on to determine where did we need to deliver our laboratory results. Our hospital certainly looked at what patients had been scheduled for urgent surgeries. So, what patients were we treating with chemotherapy? And we focused our efforts initially on ensuring that we could still deliver that quality of care. So from a laboratory's perspective, for example, we knew it was most important to work on getting our inpatient laboratory results available, to maintaining our transfusion services, because that's obviously really, really important to delivering care to patients both in the emergency department and who are in the hospital. And so we did assess our critical risky points and we addressed those items first. Yep. So for example, we stood up a resulting center, we called it a resulting center, and it was initially focused on delivering inpatient results. And then over time, we stood up an outpatient resulting center so that we could get outpatient results, which tend to be less critical and have not the consequence if it's not as timely as we would like it to be.
Well, Dr. Goodwin, is there anything else we should know before we wrap up today?
I just think it's really important to understand that in order for a healthcare organization or for a laboratory to withstand really a criminal attack, which was what was levied against us, and to respond appropriately, we are one of the components in delivering healthcare. And we, for lack of a better term, came out of the basement during this scenario. The laboratory was looked upon as an area that knows how to do operations and systems and deliver care quickly. And we became really a resource for the hospital to help continue to deliver the services. And I feel very proud of my colleagues and the medical technologists and everybody in our laboratory that really relied on their experience and expertise to continue to deliver safe healthcare.
That is wonderful. Well, I'm proud of you all too, and thank you so much for this great information.
Appreciate it.
And,
Thank you.
You know, demonstrating how the lab really does touch everything.
Thank you so much.
Thank you. Before we go, on behalf of the College of American Pathologists, we would like to urge everyone who is eligible, get that COVID vaccine and get the flu shot too. Please keep vigilant about wearing a mask indoors, physically distancing, and your hand hygiene. Don't forget it. Also, if you're symptomatic for COVID, please get yourself tested. We hope you've had an enlightening experience and that we've been able to provide you some insight into exactly what pathologists do and the extensive reach that we have across all of medicine. A recording of this media briefing will be available shortly on the CAP newsroom. On behalf of the College of American Pathologists and our members, I want to thank you for joining us today.